Okay.
Well, I'd like to welcome everyone to this Brown Bag Talk. I'm Jamie Goodrich, the Director of the Humanities Center. And today we will be hearing from Dr. Ty Partridge, who is an Associate Professor in the Department of Psychology here at Wayne State, and the Director of the Research Design and Analysis Unit at Wayne State. His research interests include the influence of urban poverty on early childhood development, adolescent risk behaviors, developmental psychobiology, emotion regulation, early childhood literacy, and relational developmental systems theory. His current research projects include a mixed method narrative study of identity development among individuals who identify as biracial or multi-ethnic, the development of a socio-historical developmental model of identity development among women who identify as Black, white, biracial, and the negative health impacts of anger socialization and self-silencing of girls through an intersectional critical feminist lens. Dr. Partridge also has over 20 years of experience in community-based research, public health and prevention interventions, and evaluation research. Recent evaluations include a multi-site evaluation of the impact of school-based health centers on adolescent health and mental health, 2 federal social innovation fund award projects evaluating interventions designed to promote positive outcomes for at-risk children between 0 and 5 years and their families, and a process evaluation of a multi-service, multi-agency intervention through Head Start and Early Head Start. He has published over 80 book chapters, articles, and technical reports, including editing a special issue on genetics and human behavior. So we'd like to welcome Dr. Partridge, who will be talking to us today about the role of school-based health centers in addressing the adolescent mental health crisis.
Awesome. Thank you. As you can see, I just can't figure out what I want to be when I grow up. And so I just decided to just do all of it with that. It's very nice to be here. This is the first hybrid in-person one of these that I've done since 2020, right? So that's always really nice. And I was thinking as I was walking over here, last year I gave a talk at about the same time and was able to talk about how my Kansas Jayhawks had just won the national championship. And then this year, we're just not going to talk about it. We're just gonna let it go. Although if somebody had told me that Florida Atlantic, San Diego State, somebody else I've never heard of, and UConn were in the Final Four of the NIT, I wouldn't have believed you, let alone the NCAA. So who knows? So it's great to be here. And I just wanted to share with you some research that we've done, really looking at school-based health centers as a mechanism or as an approach to help addressing the adolescent mental health crisis that we're currently seeing. Let's see, can this, I'll just use that one. Okay, cool. All right, so as many of you probably know, we have been experiencing a crisis in mental health, particularly for adolescents, over the last 15 years or so. And in fact, there was just a recent call from the American Academy of Pediatrics for the federal government to announce a formal federal crisis in adolescent mental health. It's accelerated so much. And you can see here, just even pre-COVID, from 2007 to 2017, we saw an increase in the rates of adolescent depression of almost 60%, 59% increase in the number of adolescents experiencing depression. And then in a recent 2017, this was from Monitoring the Future, 29% of adolescents reported that they were experiencing almost daily anxiety. And COVID has just made that worse. With COVID, we've seen it exacerbate this trend. In 2021, there was a report that showed that 37% of adolescents reported that they had experienced poor mental health during the pandemic, and 44% reported feeling persistently sad or hopeless at some point during the past year. And this is a combination of both really a trivariate pandemic of not only COVID, but increases in attacks on civil liberties and social justice issues that have really affected the younger community more strongly in many ways, and then just general uncertainty about the future that has emerged out of all this. So there's a lot of factors that come into play here. Girls in particular are struggling. This is a series of data from the Pew Foundation. Starting in 2011 through 2021, you can see the top figure here is the percentage of girls who reported feeling sad or hopeless from 2011 to 2021. Sorry, I have the wrong glasses on, so I'm trying to find the right distance here. So that went up from, what is that, 36% to 57%. So that is a remarkable increase. And you see that it's for boys gone up as well, but not nearly at the magnitude of girls. And then you can see it's even more distressing when you look at the numbers of students who have seriously considered attempting suicide across that same 10-year period, going from 19% to 30% for girls, whereas boys remain pretty much stable. And you have to think 2011 was, we were just coming off of a massive economic depression with the collapse of the banking industry and the housing collapse and how that affected the auto industry. And so, the future looked pretty bleak then for students who were thinking about, going to college and graduating from college. So the fact that it's exacerbated that much more is really telling. And, all of us that have been in classrooms and that kind of thing around campus, we've seen it really increase over the last decade in particular. Contrasting that, we see that this acceleration in mental health needs is accompanied by a serious underutilization of mental health services. Nationwide, we estimate that less than half of students that need mental health services are actually getting it. And this is really much higher for youth in underserved rural and urban areas, where you have basically mental health deserts. And there's not very good access, and there's just a ton of barriers. And again, you see this exacerbated even more for adolescents from minoritized communities, which have an underutilization rate of around 63%, with limited access there. And we could talk about, there's a number of barriers here in terms of, just the availability of mental health services, issues around stigma. There are concerns with parents as gatekeepers, and a lot of adolescents maybe having mental health challenges, but they don't want to bother their parents, or they actually, in the evaluation that I'm going to talk about, we had a number of focus group responses where students would talk about just really being dismissed by adults, parents, teachers. They come to them and say, really struggling with this, and they get met with, yeah, wait till you have a mortgage, right? And so just not taking it seriously. And recognizing those symptoms. And so as a result, you have this kind of culture that has emerged of just keeping it to themselves. One of the data points, I won't talk about it in the findings that I'm going to present today, but one of the results that we found was that 80% of all of the adolescents in this study reported dealing with stress by themselves. And a focus group, I asked what that meant, and was just met with stares of, it just means you just keep getting up in the morning, like you're not dealing with it. And it's clearly not working with that. So there's a lot of barriers and reasons why we see this underutilization. And one approach that may really help with this is the use of school-based health centers as a potential solution. I don't know how many folks are familiar with school-based health centers. Before I got into this, I was thinking of school-based health centers. Well, it's really a school nurse, right? This is a much more intensive kind of approach. School-based health centers are basically primary care offices that are physically located in the school. And so one of the partners that we had in this project was Romulus High School. Romulus High School has a clinic that is staffed, operated, completely run by Beaumont. It is a Beaumont Health Clinic. It's just physically located in the school. We have a suite of rooms that are just right off one of the main hallways in the high school. And any student at the school can use the clinic. They do need parental permission but it's a blanket permission. Any student can use the clinic one time without permission. But to use it more than once, you need parental consent. But again, it's a blanket consent. And so if there are situations where you want to go to the clinic, you don't want your parents to know about it, you don't have to go through that step of getting parental permission for that. You can just go to the clinic. Obviously, if there's a situation where parents need to be informed and it's ethical and doesn't violate confidentiality and all of those rules, we can reach out to parents and kind of come to a decision between the healthcare provider and the student. But it really removes a lot of barriers. If you want to go to the clinic, you just say, I need a pass to go to the clinic. The student, teachers can't really question it. The office staff can't question it. That's really for the clinic to decide whether it was appropriate or not. And, if you come down there just to get out of class, they're going to send you right back. So it really takes a lot of the hurdles that students may face in seeking mental health care off the table. So Michigan is a little bit unique in that the Michigan Department of Health and Human Services, who subsidizes these centers, so that, if you don't have insurance, that's fine. They're covering some of that cost. So it doesn't have any financial limitations to accessing it. But they do require that you have a full-time mental health professional on staff. So most of the clinics have, at a minimum, one nurse practitioner or physician assistant and one qualified mental health professional. Typically it's a licensed clinical social worker that are on staff full-time. And the fact that they are in the schools and the way that they're structured, they look less like a hospital kind of setting and are a little bit more welcoming. Students get really familiar with it. A lot of times you'll see that the staff spends time in the hallways in between classes and gets to know the students. So it really becomes a part of the school community. So students feel a little bit more comfortable with that. Michigan, and I will just say now, school-based health centers is the generic term for this setup across the country. Michigan does use child and adolescent health services as their moniker. So you'll see me use CAHC or CACS interchangeably with school-based health centers. But this is the 2018 map of all of the locations where there is a child and adolescent health center. The ones I'm going to be talking about are primarily the ones with the diamonds, where it is a full clinical service. So in 2018, there were 60 schools that had a full health clinic in their school. And these can, again, have just the basic foundation of a health practitioner as well as a mental health professional. But for example, I think it was Shelby on the west side, it's a middle school. They have very limited access to dentistry in that area. And so they have a dentist office in there as well. So they really try to provide whatever healthcare services are most needed with that. Michigan has the second most school-based health centers in the country outside of California. New York is another state that has a high percentage of them, but Michigan is really one of the leaders in this model. So turning to the study that we did, the data that I'm going to report on today is part of a larger evaluation that in 2015, the Michigan Department of Health and Human Services commissioned an evaluation group that I was subcontracting with, JFM Consulting, to do an evaluation of newly funded clinics. They were funding 18 new sites that year. And they wanted us to evaluate that over a 2-year period. And we looked at, physical and mental health, experiences of stress and coping. One of the things that we looked at was health literacy and reproductive health literacy. These are things like, how confident are you that you can make a doctor's appointment? How confident are you that you can negotiate with your healthcare provider about services that you need, those sorts of things. And then we looked at their access and use of healthcare, and then looked at how that impacted educational behaviors and academic success as well. That was primarily the school's interest. Just as an aside, one of the outcomes that we were looking at was seat time. how much time children spent in their classroom, and seeing if the clinic improved that. Was really interesting to me how challenging it was to define seat time because you would think absent, present is pretty straightforward, but every school has their own way of counting absent and present, and it was really hard to track with that. So we kind of came up with an approximation that did show that, go to the clinic. If you don't have an infectious communicable disease, they can take care of whatever's, you're dealing with and then send you back to the classroom so you don't miss as much. So we're looking at a broad range of outcomes. We ended up working with 4 schools in particular. We decided, given the resources that we had, rather than doing kind of a surface level evaluation across 18 clinics, to really do a deep dive on 4 clinics and really look at those intensely. And we had a very deliberate selection process for picking the clinics. They were all using the school-based health center model. The students, we tried to identify schools that served predominantly underserved populations. And obviously they had to be part of the newly funded group. And we were really looking for both geographic and demographic mixes. All of the schools had high rates of free and reduced lunch. So they were all in districts that had high levels of general poverty. But we have Romulus High School. We looked at Sheboygan. So we've got, a more urban center, a very rural center, and then Oak Ridge and Shelby middle schools are in kind of semi-urban, semi-suburban kind of settings with that. The student population in Romulus, I want to say, was about 89% Black. Sheboygan was, I want to say, 85% white. And then both Oak Ridge and Shelby had a population of about 60% largely Hispanic migrant farm worker children of migrant farm workers. And so we tried to get both geographic and racial ethnic diversity as well. And sorry about that. We were also looking for clinics that were going to get up to speed very quickly. So the funding was announced, I want to say April of 2015. These clinics need to be operational by September, October at the very latest. And so that meant rehabbing buildings, hiring staff, getting everything set up. So it was really looking at schools who also had the capacity to do this fairly quickly. And then obviously they had to have an interest in participating because they're not buying, we're not going to do this. In the end, like I said, we had 2 middle schools on the west side of the state. We had 1 high school in Sheboygan and then another one in Romulus. We looked at a prospective cohort that allowed us to look at students from 6th grade through 11th grade. We intentionally didn't look at 12th grade students to start because we wanted to get them for the full 2 years and survey them once in the fall, once in the spring across that 2-year period. And we surveyed everybody in the school. So that gave us a sample of 1,700 students roughly across the 2-year period that we looked at. We had multiple data sources that we included. As I said, we surveyed the entire school body of 6th graders through 11th graders, starting in the fall of 2015. We also had another risk assessment report that turned out to be, it's a good clinical tool, but not a great research tool, but it did have some information on there about risk behaviors that we looked at. In addition to this broad survey that we had, we also had access to their electronic medical records. And so the way this worked is that we had a medical coordinator in the clinic that was the only person who had a master list of kids' names and then an ID number that they were assigned. And then we could match their clinic record and their survey based on that ID number and still have it be de-identified. And the clinic record, basically what we pulled out of there was, when did they use the clinic? What time did they go? What time did they leave? So we can look at duration. What was their principal complaint? What was the principal diagnosis? What any kind of interventions or actions that the health clinic took, and then where they went afterwards. So was there a referral made? Did they go home? Did they go home? Did they go back to school, et cetera? So we had a lot of rich information about the clinic use as a whole with that. In addition, we also did have regular focus groups and discussion groups that we held. Each clinic, again, the state requires them to have a community health advisory and a student advisory group. So it was a student advisory committee and community advisory committee. So we had YACs and CACs, youth advisory and community advisories. And we also met with, clinic staff regularly. Every time we did every time we did a wave of survey data collection, we would take those results and bring it back to the clinic, the youth advisory committee, the community advisory committee, as well as the school administration, and get their input on what we were finding and do it sort of in a collaborative way. So we had a lot of really rich information here. What I want to focus on primarily is the mental health findings. We found very quickly that the clinics were predominantly being used for mental health services, immunizations, and physicals. Those were the big three. And when we looked at the utilization rates of the clinic just broadly, over 50% of all clinic visits were for a mental health purpose. So it was really, really driving a lot of the clinic operations. So looking at mental health, we found the same kinds of things, high rates of mental health need. And this, again, really particularly for girls, was also a struggle. We have a set of questions in our survey that asked about, in the last 4 weeks, how often have you felt? And things like felt happy, felt energetic, but also felt down and depressed, feeling hopeless, feeling like something bad is about to happen, and feeling angry. And one of the things that jumps out here is we looked at the percentage of students who answered that they had experienced these feelings fairly often or more over the last 4 weeks. And 42% of girls reported feeling angry fairly often or more. And that was the highest percentage of any of the areas that we were looking at, and substantially higher than the boys' reports of anger. And you can see here 38% reporting feelings of depression or hopelessness, and 30% feeling anxious or fearful. So we can see that, again, that same kind of pattern where girls are experiencing more mental health challenges. And the anger finding really jumps out at folks, and I'll follow up a little bit with that. We also saw a substantial increase in depression by age for girls, where there's this jump from age 13 to age 15, going from about 30%, which again is too high, to nearly 50% of adolescent girls between 15 and 17 reporting feelings of depression fairly often. In looking at the impact, this is really where the health clinic becomes a viable resource for looking at ways of reducing mental health challenges for adolescents, primarily by overcoming the barriers of access to services. You'll see here, we looked at students who had an identified mental health concern. So again, looking at multiple mental health items that we had in our survey, anybody who endorsed having these feelings fairly often or more in the last 4 weeks, split it by that and found that of those students, 55% of them were utilizing the clinic for mental health services. That's about double what we see nationally. Girls were using it again more than boys. About 59% of girls who expressed mental health concerns were using the clinic. And the way that they use the clinic is also really important. Because of the way it's structured in kind of built into the student's daily experience, we saw ranges of students using the clinic maybe once or twice for mental health services, all the way to students, the highest utilization we saw was 23 visits during the school year for mental health needs. The other thing that you can do with school-based health centers that you cannot do with other forms of healthcare and mental health care is using it multiple times per day. So we'd often see cases where a student would come in the morning and be, upset about something, they're struggling with things. They go to the clinic, they talk to the social worker, they get kind of everything centered and grounded and they're okay, and they go to class. Over the course of the day, things start to build again, they start to feel frustrated, they start to feel unsettled. They go to the clinic in the afternoon or, after lunch or whatever the case may be, get everything kind of, re-regulated and feeling a little bit better, and then going back to class. In fact, we actually had some students, one student in a focus group talked about how, very high performing student, great grades, very active in a lot of extracurricular activities, those sorts of things, and woke up one day and just like, I can't do school today. I just can't. And then she was reflecting on that and was like, how am I 16 years old and I'm already in a place where I need a mental health day? I'm only 16. That's feels wrong to me. Like, what is that? But with the clinic, found that she reported coming to school on those kinds of days, specifically so she could go to the clinic. So rather than saying, I need a mental health day, I can't go to school today, I just can't deal with it. It was saying, well, I want to go to school because that's where I can get some help with this, but then I also don't lose that learning time either with that. So it was a very positive way of impacting their utilization. And we did see that it did improve mental health. We saw a significant reduction in levels of depression and anger and anxiety. More important, we also saw a lot of an increase in mediating factors like better use of social support, better use of social or stress coping skills, that kind of thing. Reducing stress. We also kind of spun it off into some outreach programs as well. I'll talk about those in a minute. So these were some growth curves that we did to look at just generally what the level of change over time in various outcomes was. The dark blue are clinic users. So these are students that did use the clinic particularly for mental health services. And then the other line, the light blue line, are students who did not use the clinic. And I use this was a set of slides that I also used for a non-academic audience. And so used kind of a color coding scheme to talk about the magnitude of effect. So if you see a green dot, that means it was a pretty big, meaningful effect, not just statistical significance. So we saw a substantial improvement in social support. Again, a decline in feeling down and depressed. We also saw a substantial decline in learning and behavioral issues in school. And Janine Johnson, who was a first-year clinical student in our lab, recently looked at some of this data and really drilled down on this to look at the relationship between clinic use and suspension and expulsion practices, and found that students who use the clinic more were less likely to be suspended or expelled. And that's consistent with some of the anecdotal data that we learned from principals and superintendents who started using the clinic as a first line of any disciplinary referral. So rather than giving the student detention, rather than suspending or expelling them, the first thing that they did was you have to go to the clinic. And 9 times out of 10, there was some underlying dynamic that was causing the behavioral issue. And they were able to get that resolved that way and not exclude the student from the school. There were cases where students had been expelled, say for something like fighting, and a condition of their return to school was that they had to use the clinic. And so Janine did a poster a few weeks ago that at least gave us some preliminary evidence that this might be another way to kind of disrupt the the school to prison pipeline that you see as well. Coping in negative ways with stress, we saw a substantial reduction in that as well. And this is things like, just pretending that it's fine, ignoring it, or engaging in some sort of self-destructive kind of behavior as a way of managing stress. We did see a substantial increase with that. As well as a substantial increase in a more resilient way of coping, higher levels of resilience, higher levels of positive coping. So it's not that we're just preventing things that are troubling, but we're actually seeing an add-in of something that is growth oriented and positive. So we're not just, we're just not stopping the bad thing, but increasing the thing that we want to have happen as well. So what have we learned from this? We have a very high need for something to address mental health services for students and adolescents. The clinics do improve access and outcomes, and this is really important because it's an already existing infrastructure. If you look at most areas of the country, urban and rural, you have, again, like I said, sort of mental health deserts. There are very few providers. If you're in a more suburban area that's a little bit more affluent, you get more concentration of behavioral health services. It's not accessible to everybody. They're expensive. Insurance, certainly plays a part in that. But every community has a school. And so there's a natural infrastructure already there that people are familiar with. There's a lot of advantages to having the care take place in a school-based health center, in that they're very careful to say we're not trying to step on the toes of primary care providers. We're not trying to step on the toes of therapists outside. We're kind of a triage first contact. But a lot of times the quality of care that you can provide is a little bit higher in the school-based health clinic because you don't have the same restrictions that you have in a healthcare setting, mostly in terms of patient turnover. There was a focus group that we had with one of the clinics that is downriver, and they were talking about a situation where they had a student who was in real crisis. They shut the clinic down for 4 hours and just focused on this child. You can't do that in other healthcare settings. The advantage that many of the mental health providers talked about was because they were at the school, they had a better sense of the context of what was happening. They knew the kids' friends, they knew their siblings, they knew the environment of the high school or the middle school or whatever was happening kind of in the community, and could contextualize a lot of this a lot better. We actually had cases of students referring other students, where a student will come to the clinic and say, look, so-and-so, I don't know if they've come to talk to you, but they're really talking about some crazy stuff and you should probably reach out to them. And so then the clinic staff could just kind of gently approach that student and, how are you doing, how are things going, and kind of keep tabs on it, and get them in that way. We really see an impact that goes beyond primary outcomes, primary care outcomes, to really broader socio-emotional, academic, and improved developmental outcomes. Kind of having access to the mental health services that they've learned to use pretty effectively translates into higher healthcare literacy, where they are better self-advocates in reaching out and addressing their own needs. They've got some experience in directly interacting with a clinic staff that prepares them for when I need to go, see my doctor in real life, or not real life, but, outside of the school. In fact, we had conversations with Romulus High School. The principal there was really interested in how that impacted students' transition to adulthood and transition into college in particular, where for the first time they have to make these decisions, pretty much on their own. They've moved away from home. They don't have a parent there or a guardian to help guide them in that situation. They really have to make these decisions on their own. It's really benefited them that way. The clinics are really also ideally suited not only for just tertiary acute care when somebody's in having an issue or in an acute crisis or something like that, but also for more prevention-oriented programming. One of the things that we found in talking about mental health services is that students didn't share either with their parents, but more importantly with their peers when they were really struggling, because they didn't want to put another burden on somebody else. And a lot of them had reflected on their own experiences where somebody had come to them and said, they were struggling with something or they were really having a hard time and they didn't know what to say. They didn't know how to handle that. And they didn't know what the right thing to do was. And so they didn't, in turn want to do that to somebody else. So from that, the staff at the health clinic, this one school where this was brought up, actually developed a peer counseling training program where that they would work with students on if a friend shares something with you, like this is how you can approach it. This is how you can be supportive. Here are some resources that you can use to try and figure out, do you refer them to the clinic? How seriously should you take these kinds of statements, that kind of thing that really kind of broaden them out. And then, the bottom line is that if we had a health clinic really in every school, the barriers to access almost completely go away. And again, it's not only just access because you're there and you don't have to worry about somebody driving you there. You don't have to worry about access. You don't have to worry about insurance kinds of things, but also a drop in stigma as a barrier as well. If you don't want people to know that you're going to the clinic for a mental health concern, nobody knows that because you've got both mental health and physical health in the same building, or in the same set of offices, really. And so nobody knows why you're there. And so it's really puts it back in your court, whether or not you want to disclose that. And it also reduces stigma, again, by normalizing it, because you've got mental health services in the hallway every day. You've got therapists there. You've just kind of increased messaging in the school about reducing the stigma of mental health as well. So it really leads to a high level of outreach. With that, a lot of this work has, like I said, kind of led to other research projects. As I said before, Janine was looking at how the clinics can intervene, again, through mental health services and reduce school disciplinary action. The finding about young girls' experiences with anger, again, this really jumps out at a lot of folks. It did not jump out to the undergrad girls who were working in my lab, who were like, duh, have you seen the stuff that we have to put up with? Of course we're angry. But it led to this whole discussion around the socialization of anger and anger expression in young girls. And one of the undergrads who was doing her honors thesis in my lab really took this on and collected her own data and followed this up with a study looking at anger socialization for young women. At last count, she had about 400 responses from Wayne State students. I actually have a student in my class now who participated in that, and didn't say anything to Haley about who it was, so we keep the confidentiality. But her comment was to me was, I hope your student Haley has great success in her life, because this was an amazing thing. And I spent hours typing away on these open-ended questions about why socialization of anger was so challenging. And what she's finding is that well, I can sum it up. She has the greatest title to an honors thesis I've ever heard. Her title was Being Human Isn't Ladylike. Really stemming from this idea that feeling angry, how many girls get told that's not ladylike. And engage in a lot of self-silencing behavior, kind of really taking feelings of anger and suppressing that to maintain social stability, maintain other relationships, to not, let it bother other people. And then the number of girls who would talk about how, I tried to hold it in, I tried not to say anything, I tried to control my temper, and then it just finally was too much and I blew up. And then the amount of remorse and guilt that they felt. Male respondents don't respond that way. They get angry, it's fine, they do their thing, it's fine, I got angry. The girls are really trying to suppress it and then feeling guilty for feeling the way that they felt with that. And then she's finding that that's associated significantly with increased mental health, negative mental health impacts, as well as physical health impacts, particularly with a lot of somatic symptoms like headaches and stomach aches and chronic issues like that. Addressing that at the school health clinic, that became, that's another avenue for prevention and outreach, helping girls figure out how they can express their anger and that it's perfectly ladylike to feel angry. Working with minoritized youth who are often in a double bind, Black women, Latina young girls get in this double bind where if they don't say anything, just kind of, that's a challenge. But if you do kind of express frustration, it just gets dismissed as, oh, that's just an angry Black girl, or, oh, you're being hostile, you're being aggressive. And then it turns into like this disciplinary issue rather than just acknowledging this is how this person felt with that. And so the clinics really provide a forum for addressing a lot of these health and mental health issues around them. So, as Tom Hanks once said, that's all I got to say about that. And so I'll open it up to any questions that people have.
Go ahead and give a round of applause for our speaker for that. Thank you for that thought. And I think we're going to set it up so that we can see who's online here. And I think you have to turn on the camera, Sonia.
Yeah.
There we go. So, looks like we've got a comment here in the chat.
There we go. Samantha, I do have a question about how you came to know the importance of school-based interventions. Serendipity, I guess, is my answer. In that one of the persons, and with an English professor, no less, I'm using one of the persons,
No worries.
one of the people with whom I worked very closely on this, Janet Zimmerman, has been doing school-based health center work for a really long time. And I'd worked with her on another project, and when this call came out, she reached out to me and said, we need somebody who's got some content expertise in adolescence and adolescent risk behavior, but also statistics and complex data analysis. And so we got involved in this. And then the more I learned about it, and really going through this evaluation and seeing the potential of this as a public health level intervention, just that's really where it became clear to me that this is a game-changing policy kind of approach. Because it just addresses so many issues of healthcare access and barriers to care with an infrastructure that's already present.
Other questions from in the room, or looks like maybe there's a question online.
Julie has her hand raised.
Yeah.
Hi, Ty. Thank you
Julie?
for such a great talk. Super interesting. And I have some other questions that I would love to talk with you about offline. But a question that I do have for you that I'd love for you to answer is, do you have a sense from any of the data analysis you've run, what students, are there differences between which students who are experiencing distress actually utilize the services there at the health center versus those who don't?
Yeah, we did look at risk profiles of those who do use, and found that students with higher levels of social risk factors tend to use the clinic more than students who do not. So students who had elevated mental health profiles in terms of mental health need, students, it was hard to kind of parse out because it's a smaller subgroup, but students with chronic illnesses, particularly diabetes and asthma, use the clinic a great deal. And students that were engaging in more high risk behavior. And this is one of those things, we did have that risk assessment scale. It's not a very good research tool because it is, a lot of the questions are double barreled where, they'll say, have you ever smoked a cigarette, had more than one drink of alcohol, used heroin, right? So if you say yes, we don't know exactly what you're saying yes to. And they're also not, those were not confidential. They were screener forms that they filled out every time they went to the clinic. And the healthcare professional could look that over and say, oh, I see you checked this and maybe we should have a conversation about it. What's really interesting about that is that less than 1% of them were having sex. But 10% of the visits were for pregnancy concerns and STD concerns. So you do the math.
One of the things I think is really interesting, if I may, I was at the Society for Research in Child Development last week, and I went to a particular talk that was on universal approaches for mental health awareness and suicide awareness, and talking about how often the children that are or adolescents who are most at risk don't seek services, and how they really drew on a lot of research, both in terms of mental health, but also in terms of more illness literature, who talk about sort of how those folks often get missed, both because they're not seeking the services or they just get missed in lots of ways. And therefore the real usefulness of universal approaches to intervention. And one of the things I'd love to talk with you about is sort of how the dual utility of sort of more of a universal approach to awareness, coupled with these kinds of intervention, these sort of centers in a school, might be sort of the most bang for a school's buck, particularly when those universal services are so cheap.
Yeah. And, again, it kind of falls into what we were talking about in terms of these clinics as a foundation for broad public health initiatives and broad public health approaches. Because they are operated by, federal FRQPs, federally qualified health services, they do still tend to have a focus on outcomes like, number of unique individuals served. And it does take some advocacy to get them to think more about public health prevention oriented approaches. But when they see the impact that it has, it's typically the hospital administrator billing office that's more concerned about it than the staff. They're usually pretty much on board.
Thanks, Ty.
100%.
Oh, looks like Samantha has another question in the chat.
Any ideas for future programs on health literacy for older adults? That's a great question. Probably have to talk with someone from the Institute for Gerontology, might have some ideas about ways to distribute the training. But older adults are often finding themselves in the same kind of dilemma as younger adults, because the navigating our healthcare system from a patient user perspective is unbelievably challenging. I think about this all the time when I've dealt with stuff, hospital stuff, insurance kinds of stuff. And I think, I've worked in this field for a while, got a PhD for what that's worth, used to navigating bureaucracy, and this is really challenging. If you're an older adult, especially if you don't have a lot of support and are starting to have challenges with cognitive decline and that sort of thing, this becomes completely overwhelming. In a much the same way that adolescents would feel overwhelmed. So having these kind of scaffolded service providers that give you the skills for this is how you handle it, in these different situations, I think there'd be a lot of parallels we could draw. I just don't know about them, I could see it through community centers, that kind of thing. The advantage, and you could even include this with schools, because a lot of these communities where these are located, the school is the center of the community. And so incorporating not just the students, but, on weekends or after school hours, having folks from the community who are not students utilize the services could also come into play here.
Yeah, I was thinking senior centers would be a good.
Yeah, senior
Would
centers.
be a great place for a clinic. This-
Yeah, it's the same model.
Yeah, this makes me think, though, I was thinking about your point that a lot of these school-based centers are in mental health deserts. So what happens to the kids when they leave the school?
It'd be really interesting to track and see where they went. We know broadly that a lot of the communities, particularly rural communities, the students leave and don't come back. And they're migrating to more urban centers. There's more opportunity for jobs and those sorts of things. And so, they're in places where they have better mental health access. But even in places where there's better mental health care services in the community, it becomes a numbers game where you just don't have enough providers. We looked doing some preliminary analyses at utilization. We looked at the number of providers within a 30-mile radius of Shelby Middle School. And that's, again, sort of a semi-rural, suburban kind of region. And, there's a number of mental health providers there. But if you look at the number of students that are using the clinic and the number of providers, and you get 45 minutes per session, maybe 6-8 sessions a week, you could serve about 10% of them and give them one visit. There's just not enough numbers. So even in cases where there are more services, these really help just reduce the demand. And almost all of them, we see almost a 100% referral rate from the clinic to an outside service.
See, Walter's got a question in the chat, and then we'll see if there are any questions from this audience here. I want to make sure that those in the room can ask a question if they like.
Reasons for gender differences between students. Yeah, I wish I knew the answer to why there are gender differences in the mental health need, if I'm reading that correctly. I think it's a pretty complicated issue in terms of issues around socialization. There may be higher rates among boys, but they're not talking about it in the same way. They're not talking about it with the same language, so it doesn't appear as depression, but might show up as more substance use or, again, issues with anger, even though girls are talking about feeling angry more often. The other thing that we saw with gender differences, again, comes down to socialization. And one of the girls in a focus group put it best. She said, the boys all have outlets when they're feeling frustrated and aggressive or angry. It's more acceptable for them to kind of have an angry outburst, or they're playing sports and can kind of get this anger and angry energy out, or there's some more physical way of expressing it. That girls, if they do the exact same thing, they're like, oh, you're problematic with that. So there's probably an underrepresentation of boys because they're socialized to not talk about it. And then, just the issues that you see with, as the students in my lab said, the crap that we have to put up with, and the kind of growing social consciousness of just because I'm a girl doesn't mean I can be treated this way, or that you have these expectations of me, and sort of starting to push back at that, and dealing with misogyny at a very young age. And then you start layering on the intersection of gender and race, and it becomes even more expounded with that. So I think there's just a lot more frustrations to deal with too, as well.
Any questions from inside the room?
In terms of funding, so the whole idea sounds really phenomenal, but then what if Michigan be adjust size?
We hope that they don't start cutting funding. It's an ongoing challenge because resources are finite and we have to make decisions about that. And I think that's one of the reasons why this kind of data is so important, and to not share it just with academic journals that 3 people read, but to get it into the hands of folks that can actually make a difference with it. A case in point, there's a Rosemary Bear, who's a state senator, is someone that I've known for a really long time. She, before entering politics, had a company doing data management, dashboard development, data warehousing for nonprofits. And so she's really into data, and we've worked together outside of her role in the Senate for a long time. And she knew we were doing some of this work. And she called me it was like a Thursday afternoon, and said, there's this mental health bill that's been in committee forever. It looks like it's finally coming out. They're going to have a vote maybe Monday or Tuesday. Is there anything that you can get me to help lobby for this? And so pulled together a really quick 1-page infographic showing some of these same kind of results around mental health need, the high levels of utilization. And then that ended up getting an extra $5 million in mental health funding through that. So it's really important to advocate for the importance of it and make it as visible as possible. And especially, when you can start combining individual stories with things like economic impact, the cost of funding a clinic versus the cost of unmet mental health needs on society. There's a huge cost benefit analysis to putting it here. But yeah, it's always an ongoing struggle of how do we fund this? And issues of underfunding. For example, Ann Arbor has a clinic that's very large and has multiple healthcare professionals. And one of the nice things about that is that they can provide debriefing and supervision for each other. Whereas in some place like Sheboygan, where there's just 2 people and an office manager, the secondary emotional toll can really wear on you and have high levels of burnout with that. But yeah, just keep advocating. Anything else?
Other questions for our speaker?
Pardon me?
I said other questions for our
Oh.
speaker, yeah. From online or in the room?
I had one.
Yeah.
When you were reaching out to the different schools that you eventually worked with this program, was there a difference in the time and willingness of the different schools, that depending on the area that they were in Michigan, to embrace this sort of this program?
A little bit. I mean, we're sort of self-selecting a little bit in the sense that they had to apply to the state to have a health center. And so they'd already gone through the work of, like, as a community, is this something we want to pursue? As a school, is this something we want to pursue? And putting it forth. That being said, there were differences in resources available and timing. One of the clinics really didn't get to be fully operational until almost December, because of just the school was smaller. They set the clinic up in a trailer, a kind of a mobile unit that was in between the middle school and the high school. It took a while to get all the appropriate equipment and stuff in there. So there are differences in how prepared the schools are. Whereas, for example, Romulus had really done a lot of groundwork before submitting the proposal, so they hit the ground running very quickly. And then I think it was Shelby, if I remember correctly, that also wanted to include dentistry. And again, that slowed them down a little bit, but they opened the mental health and physical health stuff pretty quickly, and then the dentistry came online a little bit later. So there's definitely differences. And again, if we had more funding, we could probably equalize that a little bit. The other challenge that comes in is the staffing is expensive. You're talking about $90,000 to $100,000 for a nurse practitioner, physician assistant. Again, much cheaper than an MD, but it's still a heavy burden with that. Any other questions? All right.
Well, then I'd like to thank our speaker again, to give him in person and a digital round of applause.
Yeah, very nice talking to you, everybody.
And thank you all for coming. And thanks to the speaker again. Thanks. That was a wonderful talk.
Thanks. I appreciate it. These are always fun.